Thank you very much for your coming to Jeju Island. So during stay in the Jeju, we wish for you to have a good and joyful times. My position is very unique. I'm a head of the company and also is the head of the development, research and development, and also I'm a clinician together. So we do that positions and we tried to make some good materials and to be used very simply, efficiently in the various difficult situations. And before, dental implant was very difficult to apply by the young and the unexperienced doctors. But nowadays, with the development of the materials, however, you are not so much familiar in the surgery, and every treatment became to be very simplified. And already, Dr. Lim have mentioned very well about the collagen graft, and also the xenograft, also xenocollagens. And before treatment, GBR is one of the most difficult treatment, but now they became to be much more simplified. So I will try to explain more and more, step by step about that. And today, when you do developed of the materials and the basic concept of them must be simple and finally must be efficient. Efficiency means and simple and with a good result. So based on that, and we try to develop the materials and the applications very simply. So relatively, I have a longer times, and so I will explain much more from the introduction to the sinus segmentations. First about in the secondary about the small defect, large defect, and some biological materials for the enhancing and promote the healings, and after about the sinus segmentations. Especially conventional GBR is very familiar with the particulate bone and the collagen membranes, but for them, with many complications, and also patient after the surgery, there is too much traumatic surgery, especially with the periosteal leading incisions. And also sometimes there is some 3D print titanium plate, and the sausage technique is too much widened of the flap. So after surgery, also even surgery and after surgery is very difficult to care. But we tried to simplify it without so much periosteal releasing incision and without so much difficulty of the surgery, and we tried to from the conventional to the challenge the GBR is that is means and the osteocollagen collagen and the collagen graft. So when you do define of the defect is a small defect less than 3 millimeters, large defect is over the 3 millimeters, and also defect is two different types. One is the contained defect, another is uncontained defect. In a contained defect also we can use the particulate bone, but in an uncontained defect, particulate bone is very difficult to manage. So at the time we do use the osteocollagen collagen. And also in some small defect relatively easy to manipulate, but in a large defect it's not so much easier. So first we recommend the staged approaches, first bone grafting and later on implant placement, and with the additional and the hard and soft tissue augmentation together. We have a long time history of the development from the synthetic bone and also xenograft, and in the future with the combined with some the other content to make some tissue, soft and hard tissue healing faster. So this is a long time history because yes, when you develop the bone graft material to be a synthetic instead of from the animals. So that is a late industrialization of the xenograft. But when you do evaluation of the xenograft, there are many things to do discussions because we have over the 20 years history of the evaluation. So we became to more and more. Before we didn't know exactly the details of the each concepts, but nowadays we became to know information about them more and more. Also, recent our very interesting approach is combined with the bioactive glass. Sometimes we do evaluation is 10% and also 20%. So we are now evaluations because bioactive glass is fast bone formations. But one side effect is at the time of with the fast resorption of them is pHs. Is too much highly increased. So during the grafting is will be an alkaline situation. So there is a very good antibacterial effect, but also there's some damage to the new bone formations. So anyway, in an animal study, 8 weeks later and 6 weeks later is vertical augmentations and bone formed very well. And also some small defect is within 3 millimeters. Is very simply we can do augmentation without any special approaches. Is osteocollagen and the collagen graft itself. That is good enough for the within 3 millimeters. Is very simply we can do augment in the lower. And the relatively wider situation is much better. So from temporary and the posterior during the follow-ups, bone can be formed very well and maintained very well. And also even the soft tissue continuously maturations also sometimes interproximal was filled very well with the effectiveness of the collagen graft. At first also we used some stabilization abatement, but actually nowadays we became to know that it's not needed. So with the polymer healing abatement, and that is good effectiveness for the stabilization of the membrane and the collagen graft. And also already Dr. Lim have mentioned about the bright implant system, tissue level and the bone levels. Is a tissue level actually we are from the 2.0 to the is over the 3.5 and the diameter 4.0 and also 4.5 and 5.0s. So, but in China that is a diameter from the 3.0. Also, we tried the clinical study of this narrow diameter with the university in China. And this is a 2.5 diameter implant is very important especially in the very narrow alveolar ridge. In the posterior is a diameter 3.5, 7 millimeter lengths is good enough. So short and narrow diameter implant with this very strong point for the efficient treatment and have a good result. And also in this X-rays, you can feel that we do drilling only into the cancerous, not grinding out the labial cortical bone. So surgery is also very simple. However, labial bone is sometimes is 1 millimeter labial bone can be maintained very well with a narrow diameter and without some pressure to the labial bone. Also, 3 millimeters over the tissue level and the bone level is biomechanical evaluations. And so over the diameter, if the diameter 3.5 of the bright implant can be used very well for the single molars. Sometimes is some different approaches before 3 millimeters over the alveolar crest, but if we press the bone levels and sometimes 3.0 diameter implant can be used in extreme cases or connected to the other implant together. This is a Professor Park of the Yonsei University, and he does soaked with the PDLN, also osseointegrations is 1.5 times faster. So with this data, and we can do much more early loading, also especially in the aged patient and also diabetes mellitus patient, because from nowadays and from time to time, much more patient became to be aged, and also DM patient is very highly increased. So with the narrow diameter, higher strength, even in the identous cases, or minimal number and the short and narrow implant can be placed, narrow implant and the short implant posterior. So that means that is the concept of the placement of the implant in the oral necks can be changed. Not so much longer implant with the tilting, and the zygoma implant is not needed anymore. is a final processes. Also in the upper is a narrow 4 implant is good, and is a anterior is a diameter 3.0, posterior is a 4.0 implant, and the 7 millimeter length implant are good enough for the oral necks. And this is a case is the upper anterior is a very simple case after due to root fracture we have extraction and place the narrow diameter implant. Diameter is 3.0 before and after. And after the implantation, we do bone packings very densely, and also that gaps was covered with the collagen graft. With the healing abutment, collagen graft was covered the defect area, and so that means there will be a much more room for the keratinized gingiva on this side after suturing. And the collagen graft was placed, and very fortunately we have a very good collagen graft development in the sterilizations, and the gap filling is with the synthetic bone, with the bone grafting, but soft tissue gap grafting with the collagen graft for more keratinized gingivas. And also for the loading, of course, the immediate loading is very good, but sometimes 5 to 10 times failures. So connection to the other JEJU tooth is with that is very successful. So with a little bit is arms to the connected to the other JEJU tooth is very helpful. So same day or 1 or 2 days later is connected to the other JEJU tooth. So occlusal force can be spread to the other JEJU tooth, and with that, and we have a very highly success. And also with the keratinized gingiva was formed over the collagen graft areas. And at the time of the final, so sometimes screw hole can be converted to the lingual side. So after the final process, and we have a very good soft tissue profile on the labial side. Collagen graft also mentioned that there are 3 different ones, 1 density, 2 density, and 3 densities. So these are higher magnifications, and 1D is a little bit difficult to sutures, but from the 2D is possible with the sutures, and also resorption rate is much more slowly resolved. So also density is different, so depend on that we can select the different density material and the application in a different site. So in this case it's a little bit shrink the area, so we do some collagen graft into the labial side, so we can after the surgery we can see the labial tissue was augmented. Also, we can see the PDR lens socket. So already I have mentioned this PDR lens socket or PN socket injection directly into the drilling site is very good for the especially aged patient and also diabetes patient. And there is a volume sulfate on the labial side. The implant only into the cancerous area, no trauma to the violation to the labial cortical bones, and also with the volume space, and we have a very good soft tissue augmentation on the labial side. So during the healing, labial volume was augmented very well, and also soft tissue volume was good. So at the time of the final process is here, and the tissue was augmented and was maintained. So in this patient, and some patients they have some problem in the upper and the lower anterior in this side, and also upper tooth is some periodontal problems. So lower anterior side with the extraction, there is a so severe bone loss at first with the bone augmentations on the alveolar crest. And also after implantation with the socket preservations, and also later on when you do implantation, we can see some bone defect. So some bone socket preservation and the bone augmentation in the lower anterior, and 6 months later, and we had placed the 2 implants in the lower anterior side. And also on this side was a bone defect was very well matured during the function of with the temporary crown. Lower anterior also we placed the narrow diameter implant. And after extractions, we can see some severe defect on this side. So at that time, we did a very conventional approach. This is a particulate bone and the collagen membrane. We did that, and after the surgery, 1 day later, and with the oral packs and the soft tissue was very well stabilized. And the temporary crown connected to the adjacent tooth. So with the temporary crown, and around 7 months later, when you do the surgery, I will little bit shrinked. But anyway, from the incisions, and after removal of the pin and some movable bone graft materials, and there is some defect on the labia side, but we have a relatively very good bone formations on the extraction side. So with the intramalleolar penetration and also 2 implant was placed. The diameter is 2.5 diameter implant. And I'm sorry to explain of the TL2 is a new development for the evaluations. And the intramalleolar during the intramalleolar penetration, we can see the bone was formed very well, and also there is a very sound breathing through the intramalleolar penetration site. And before, compared to the before, with the particulate bone and the collagen membrane, and the defect is too much small, so instead of that, we placed the osteon collagen and the collagen graft. And with the suture, with a little bit opened, and the oral pack was placed. Oral pack is a reservable pack, and that can be sustained is around 2 days. And 2 days later will be reserved. But during the initial healings, and the oral pack is very good for the wound stabilizations. This is a videos after the bone augmentation and press the implant and the osteon collagen grafting and the osteon collagen and the collagen graft placement. At first there is so much defect. So at first with the collagen particulate bone and the collagen membrane was placed, but later on we did osteon genocollagen and also collagen graft was placed. So alveolar crestal incisions to the alveolar crest, and so little bit extended flaps and the little small vertical incision only into the keratinized tissues, not so much extended to the mucogingival junctions. The minimalized flap elevations. And the clear cut to the bones, and started the flap elevations. And we can see that some pins and some movable tissue was completely removed. And the implant positioning with the high-speed balls, and also intramalleolar penetration together. And with the narrow diameter implant, and however we placed a little bit defect side, is a minimal exposure of the implant. Check the position and the angulations, and the 2.5 implant was placed. However, there are some defect, is a very small defect, so bone augmentation would be very simple. Tried to adaptation of the collagen graft. And below there, and we do try to use the osteon collagen. Yeah, this process is very simple. This due to resorption of the collagen and a little bit shrink. That around, we are guessing 20 or 30% is a grafting will be collapsed. So sometimes we do little bit over augmentations, and the collagen graft was stabilized over the cover screw and the sutures. At the time, we did not do any periosteal releasing incisions. Nowadays, we are trying to minimize the periosteal releasing incisions because the collagen graft is very good healing, however, opened. And the sutures, and the healing, and with the oral packs and the soft tissue is very well stabilized, and the healing was good. Sometimes we also some Botox injections on the mentalis muscle areas for immobilization of the labial flap. Also sometimes in the lingual area together, because the two wound stabilizations is very important. So for the demobilization, you can use the pin technique or sometimes titanium mesh techniques. But I will do much more detailed inspirations with the dense collagen graft on the labial side, and the Botox treatment is very effective. So with that, and we tried to make a temporary crown, sprinting to the adjacent tooth, same day or 1 day later. Also in the posterior side, they are same. So at the time of the surgery, but during the healing bone, this is a second molars. But from time to time, bone became to be matured around the implant. So also for the soft tissue augmentation, at first we thinking about the filler injections. Filler is made by the hyaluronic acids, but nowadays we are thinking about if hyaluronic acid depends on the elasticity, resorption rate, the timing for the surgery is different. But nowadays we are thinking of the PN injection 2 weeks before the surgery would be very effective for the soft tissue augmentation and also very fast soft tissue healing. So not yet, and we are now on the way of the evaluation. At the time with the injection of the fillers for the soft tissue augmentation, and those 1 month later, so a little bit more, and we tried the surgery, and with some tissue augmentation would be very effective. Also on the labial side, the 2 density of the collagen graft. In the crystallized is 1 density for the fast accelerations, and the sutures healing, and with the temporary crowns. And now still continuous evaluations of the tissues and the soft tissue augmentation around that. If there is not so much keratinized tissue, in future we have another friend to making a keratinized tissue on the labial side. Next is about the treatment in a small defect. Yes, in the upper entry is alveolar is very weak. So at the times, long times ago, maybe around 8 years ago, we placed the slimline is a diameter 2.3 diameter implant, and we used the osteon collagen and the collagen graft on the labial side at the time of the finals. And during the follow-up, around 9 years later, is without gingival recessions and very good soft tissue healing around there. Over the 9 months, it's very good stabilized. So osteocollagen and the collagen graft is very good for the labia soft tissue maintenance. As you see, low entry is bone is not so much good conditions. So with some exposures, areas was covered by the osteocollagen and the collagen graft and the suture. And at the time of the finals, and there is not so much mature of the soft tissues, but 9 months later is a very good maturation of the soft tissue. We have a very good prognosis. Also in the upper anteriors, around 5 years later, upper anteriors implant was, however, diameter 2.5 or 3.0 is good enough in the upper anterior tooth. And as you see, the alveolar is too much thin, so we one implant 2.5 and 3.0s. And however, some exposure osteon collagen and the collagen graft was covered. On this side, also we can do covered, but we did not do anything without exposure. So labial bone around the remaining bone around the 1 millimeters. Usually we do recommend at least 1.5 millimeters on the labia side or 2 millimeters, but that guideline only for the standard implant. But if you place the narrow diameter implant, the ideal remaining bone on the labia side would be different. So, augmentation area is during the follow-up maintained very well, and without any augmentation area, however, labial bone was less than, almost 1 millimeter can be with the narrow diameter bones, and it maintained very well. So on this is a follow-ups and augmented, the area is bone was formed very well. Also very thin bone was maintained also very well. So with the narrow diameter, and especially in the anterior side, upper and lower, the labial bone can be maintained very well. Especially if we need some augmentation, we can do some osteon collagen and collagen graft. Also upper anterior, there was a defect, so we have used. And also during the follow-ups, and the bone was maintained very well. And also there is an impacted canine without extraction, with a little bit avoiding the impacted canine, we place the implant. So after the surgery healing, at the same time of the second stage surgery, with a little bit lingualized the semilunar incision, push the gingiva on the labia side. So during the long-term follow-up, the labial volume was maintained very well. That means that osteon collagen and the collagen graft is very good for the labia soft tissue, soft and hard tissue volume maintaining. Instead of that, and we use the osteon collagen, the collagen membranes. Collagen membrane also can be used at the times. We have little trial, is different types, but in this situation also labial bone was maintained very well. And also canine areas, the bone was thin, so we placed the implant without additionals, grafting. So is a labial emergence profile relatively good, but not so much ideal compared to the collagen membrane, collagen graft. So we need to evaluation of the collagen membrane is good for the bone formations, not so much good for the soft tissue augmentations, but collagen graft is much more effective on the labial emergence profiles. And during the follow-up, also, yes, also good maintained. So in the anterior side, so we tried place the very narrow diameter around 2.5 millimeters. After the temporization, after the final processes, and at the time of there was some fractures. So we do sometimes we do consider about is a 2 implant or 1 implant, and to save this root. So in the long term follow-ups and to saving these tooth, we became to know that is very successful because we have developed a root canal implant. Sorry, this is a video of them of the upper. As you see, there is some collagen graft and the osteon collagens. Bone was very thin, so we must have selected the very narrow diameters. The only grinding into the cancellous bone placed the very narrow diameter implant. Before the flap designing, we are thinking about the bone conditions. Sometimes we can use the pin guide to check the labral and the lingual bone conditions. But at the times, and depend on that, we can decide the flap elevation or the flapless surgery. So we did, through the bone conditionings, we became to know that alveolar crest is too much thin. So we decided to making a flap would be better for the safety of the implantation. So we did a little bit semi-rural incisions. And the flap elevations. But as we have imagined, bone condition is not so much good. So we did making a little bit more wide flaps. And as you see, the bone condition is not so much good. Yeah, alveolar crest is very sharp, so not so much easy to do drillings and to the palate, very knife edges. So with the positioning with the high-speed bars, because there is sometimes in a slope and a very sharp area is not so much easy to do positioning with the conventional pilot drill of the implant. So with the high-speed bar, we first with the positioning, decortifications, and the implantations, and the positioning and the angulation checking. And also parity is also there was a defect. So we did a little bit more small size of the collagen graft on the palatal side. And after the implant placement, also on the labial side with the collagen graft. And the osteum collagen was grafted between the membrane and the fixtures. And the sutures. Stabilizing sutures with the 4.0, and the additional sutures is a 5.0. After suture, and the healing, and with the temporary crown, and we waiting relatively longer times for the complete maturation of the soft tissues. At the time of the final processes, we became to know that palatal tissue is a little bit higher to the labial side. So sometimes in the situations, you can do a little bit more lingualized incisions, and that was positioned on the labial side. As you see, and this soft tissue was positioned on the labial side to have a much more balanced height between the labial and the palatal side. And with that, and we're taking a temporary again, and the final processing with the forehand, and at the time, and we make a screw on the labial side, and the labial hole was filled with the resin. Also in the posterior side is a small defect. After instructions, there was a bone defect, and around less than 30 millimeter defect is relatively easier to do augmentation with the collagen graft and the osteogen xenograft. So 1 year, and 8 years later, you can see the bone was made very well augmented on the not only the crestal area and the buccal area together. Also, and also in the molar side, after instruction, immediate placement of the implant in the instruction interceptor area, and the bone was formed relatively well. And as you see, interseptal bone condition was good. So with the drilling only into the septal bones, and the implant was 3.5 diameter implant, and the collagen graft was placed. Of course, at the time we haven't used some specialized healing abutment, but nowadays we began to know that it's not needed. Over the cover screw stabilization itself good enough. So 1 year later, and the temporary crowns, and we can see some space. So we make final processes, and also we can see some small spaces, but these small spaces can be filled. There are two reasons. One is the contact point to the alveolar crest, another effectiveness of the effectiveness of the collagen graft. So still I don't know exactly, but these spaces was filled very well. So collagen graft itself is very effective. So some small, from the small to some extensive cases, the patient have some periodontal problems in the upper anterior side because to maxillary, bilateral maxillary protrusions. So we decided to aesthetically and not only the aesthetic, also functionally together. So in the upper extraction, and the lower implant was also placed. Before, relatively difficult to place the regular diameter implant, but with the narrow diameter implant, every treatment became to be very simplified, and also have a very good result and prognosis. Also, diameter 3.02 implant was on the upper lateral incisors. And another implant, because we tried the extraction of the first premolar due to some periodontal problems, and so we do additional extraction and place the implant on the canine side together. So socket preservations in the content defect with the particulate bone, and also over there collagen graft was covered and sutured, and the lower are same, and with the narrow diameter implant was placed. The diameter is a 2.5 diameter implant. And also socket and some gap filling, and also there is some defect on the labial side. So very small incisions and some augmentation on this side with the collagen graft. And instead of the sutures and with the pin technique and for the stabilization of the collagen graft and the suture, and it was finished. So during the healing, is very well healed, and also lower side some exposed collagen graft was very well healed, and also on this augmentation side also are same. So with the temporarizations, you are waiting for the final processes with the temporary crown. And the patient is a bimaxillary protrusion, little bit retreated, so we have a very good mouth closing. In this patient also very similar situations, we do extractions because the patient have some discomfort on this side due to exposure of the thread outside of the gingival. So at first we do cleansing on this side, so patient symptom little bit decreased, but we are worried about the exposure of the implant side because there is already some bone loss on the labia side. So we decided to place the two implant and the extraction of them. And also with the cantilever, little bit worried about the biomechanically, but this is bright implant tissue level is strong enough, so without any hesitation, we did the extraction. So in the alveolar ridge also was very thin. So after the crestal incisions, and also thin gingival is a soft tissue augmented with the collagen graft together. On the labia, the previous implant was extracted, and very simply, maybe you are not familiar to the extraction of the implant, but through this video, you can see that implant removal is very simple and minimal traumas. So alveolar crestal incisions. And the implant positioning with a high-speed bar effort because alveolar ridge is very narrow. So after that, drilling. We have a long time history of the implant surgery, so if you're not familiar to do this without the distal guide, and especially young doctors to try recommend to use the distal guide. So after the 2 implant placement, and at the time of the implant, yes, 2 implant was placed, 2.5 diameters, very well stabilized. And the drilling only into the cancellous, not grinding out to the labial cortical bone. So at the time of the implant removal, so with the largest, longer shanks, number 330 balls, and on the other side is a little bit deeply grinding out. And usually 3 or 4 millimeters grinding out is good enough for the implant removal. So nowadays it's not so much common, but in future, more and more implant removal cases will be increased. So we must be thinking about how to implant removal very simplified, like tooth extractions. But at that, there are 2 approaches. One is the healing abutment and also with the cover screw. But nowadays we become to know that with the cover screw much more convenient to place the collagen graft. So implanted the removal site and some defected site with the content defect was grafting with the xenograft. Content defect is a particulate bone. On content defect is osteocollagen, collagenate bone into the uncontent defect. Yes, now when I do review of this case, is collagen instead of the collagen membrane, and the collagen graft was much more recommended. So this is a previous, we have various trials, but nowadays, not to use any more of the collagen membrane nowadays. And for the little bit bone augmentation with the particulate bone and the membrane, and also we tried to cover that with the collagen graft for the soft tissue augmentations. But if I do again, and we did not do any more collagen membrane applications. And after the suture and the immobilizations, we are, as already mentioned, I recommended the immobilizations with the Botox instead of any pin, and the suture, and the reservable pad. And this is a video how to remove, but I'm sorry to skip. And as you see, there is some exposures, but the collagen graft was good, but that is not good enough to immobilization the labial flaps. So we must 5 units Botox injection on the submentalis mentalis muscles. And after the temporary, and we have finished with the final processes and the intraoral scanning. So during the intraoral scanning, as one is interesting, and so fluorescence in a long pontic missing area, sometimes it's not so much accurate and easy to do taking a accurate image with the intraoral scanning. But with a little bit adding of the fluorescein, at the time even in cross arches, it's very precisely fit without any additional abutment. So with this one and without that, when you do stitching together, so that is not exactly fitable. That it means that with the fluorescein is very effective to taking a very accurate images, even in covered pontic areas with the intraoral scanning. So with that, with the designing, also at the time of the placement of the final processing, we have a very passive fitting and the screening of the final processes. So we have finished with that. And the 3-layer blocks without any coloring and staining. Already mentioned in the efficient treatment is the best for the development. So we developed the 3-layer blocks without any coloring and staining, and the placed into the mouse was finished. And the next about the Raj defect. Raj defect is there is 2 ways, the 3 ways in a Raj defect is a sausage technique, titanium mesh technique, or 3D printing of the bone graft, bone blocks. But every treatment is not so much easy and also very traumatic. So this is a very conventional titanium mesh techniques. Also, very fortunately, we have a very good result. And during the follow-ups, and the bone was very well matured and very good result. And also sometimes we can do 3D printing block bones. But surgery is very difficult, and sometimes with the exposures, we must completely removal of them. So when you do evaluation again on the Raj defect, already in when I did the presentation in the introduction, so with the collagen graft and the osteum collagen is very good result on this side, and the sinus augmentation together. So on this side is a bone augmentation with the osteum collagen and the collagen graft, we have a very good result. So after removal of the previous implant is very natural, or is severely traumatic tooth extraction is very common. So yes, on this side also we can do some PN injection for the soft tissue volume augmentations. But anyway, with the defect side, with the intramallar penetrations, contained defect with the particulate bone, uncontained defect with the collagenate bone, and covered with the collagen graft 1D. Sutures and the temporary crowns. And in this patient, when you place the temporary crowns and with the soft tissue augmentation, patient is a very little bit painful because collagen graft itself finally we came to know that is effectiveness thickening of the soft tissues. So in this case, failure cases of the bone grafting. So after instructions, and we do at first is osteum collagen, and the collagen graft was covered. After instructions, we did the surgery, and at the time there was a very severe defect. So at first with the collagen graft on the labia side for demobilization of the labia flap and the osteum collagen, and covered with the collagen, this is a 1D, this is a 2D. 2 demobilization of the labia flaps, 1D for the fast epithelializations, and the sutures without so much periosteal leading incisions. And the healing 3 weeks later, we are waiting. So on this patient are same, after instruction, and the similarly approaches, and maintained. But during the healing, you can see that is a much more bone formation on the alveolar crest. I think that is the effectiveness of the collagen graft. And also, when you place the implant, is intentionally 1 millimeters over the alveolar crest, and we have a confidence of the collagen graft effectiveness. So anyway, after instruction, we already mentioned the 3 is small balls, and the 3 to 4 millimeters to the around the implant side. After removal them and the osteum collagen and the collagen graft over there, sutures. 6 months later, when you do the surgery, after flap elevation, we became to know that there is a bone formation. So we placed the 2 implant, bone level implant, and without anything, only collagen graft was covered, and also bone level implant, little bit 1 millimeter over the alveolar crest. And the sutures, not yet follow-ups, because recently we have finished of the surgery. And also in a very large defect lower anterior side. Some socket preservation and the effort we did, the perineal diameter is a diameter 2.0, and also bone socket preservation, and the bone was formed very well. So without flap elevation, we placed the additional 2 implant. And this is also very common before. So after extraction, complete removal of the soft tissue, there is a very small bones in the lower anterior incisor area. So we placed the 2.0 diameter implant, and with the contained defect with the particulate bone, uncontained defect with the collagenate bone, and covered by the collagen graft, sutures. But suture was good. 1 week later was good, but during the follow-up, we can see that some the gingival recessions and also tearing of them. And in this situation, we became to know the labial soft tissue stabilization is very important because there are too much movement by the mentalis muscle. So Botox injection on the mentalis muscle, sometimes on the lingual side, it would be very important. So when you do sound, the bone was formed very well. So without any flap elevations, we placed an additional 2 implant. Through the temporization, this is a video, but very simple, so I will skip. And after that, intraoral scanning. Also, we use the Shiny 3D Elite. It's a very good photogrammetric concept of the intraoral scanning, very precise. So even in cross-arch, I already mentioned with the floor resin is good enough without the additional abutment. And with the 3 implant, and we have placed the final processes, century and eccentric, 3-layer block without any coloring and staining, and placed into the mouth and finished. Also, with the intraoral scanning, we became the very precise, and screw fitness is very flexibly. And in this patient is a very higher clenching habit, so we tried to control them. Also, sometimes in a highly clenching patient have a very obstructive of the airway. So patient have snoring and sleep apnea. So we try to make a sprint in the lower side. If you place in the upper side, there is not so much effectiveness for the airway widening. Because when you do place in the upper side, also there is some spacing of the thickness of the sprint. But when you do place in the lower anteriors, as you see, is not over the lingual side. Inside the lingual curves, and so not too making a space for the sprint, to making some space for the tongues. And only from the canine side is a little bit over there. And with that, and pressed into the muscle and first finished. So when you do evaluation and before and labial, little bit widening. But immediately, it's a little bit widening, but for more evaluation of after the maturation of the tongue movement positionings, and 1 month later, usually became to be better. Yeah. So about the PDLM, PN, and the PHs, as already mentioned, one very interesting after instructions. And after that, and the 2.5 months later, so in the X-ray, it's not so much mineralizations, but there is enough density of the bone. So we place the implant without the additional graft. We have finished. So at the time of the extraction, we can see that there is some pathocysis and also just very simply PN injection, because PN is a gel. So just this PN injection to the end and bite cause itself is good enough for the fast bone formations. Also, even in the curatages or periodontal flap elevation or traumatic surgical extraction, if you do inject the PN, very simply injection, and the soft tissue and the hard tissue healing is at least 2 times fastly healed. So 2 months, 2 weeks later, when I do flap elevation, I was surprised. Not only this case, the other cases are same. After 2 or 3 months later, bone already became to be healed. So just implant placement without anything with the sutures and finished. So also PN is very effectiveness into the implant drilling site. So already mentioned diabetes mellitus patient, and also for the very aged patient, we do intentional PN or some bone graft site areas. And 3 or 4 weeks later, we have a very good stabilization, but at the time of this insertion, we have not so much good stabilization, but some weeks later, we have a very good result. Also, PDRN is a solutions, but PN is a gel. pH with the hyaluronic acid is much more consistent effectiveness. So that is very good for the TMJ product therapy. So as you did that, and after the pH injection, 6 weeks later, patient with TMJ problems symptom was very well controlled. Also, not distance, but also we do evaluation exactly about the TMJ positions where this is so with each bone segmentation, with the information of the exact position of the TM joint, and in feature, that image is very helpful for the TMJ treatment. Also, in this patient is at first Botox injections for the control of the occlusal force, especially on the lateral pterygoid muscle, and there is a symptoms. So we do injection onto the sternocleidomastoid mastoid muscle together, because the patient is alveolar TMJ condylar position is too much superiorly. So at first the pH injection, and also nowadays we became to the with the flow of resins 0.5 to 1 millimeter. So unilateral occlusal increasement is very effective for the good stabilization of the TMJ positions. So as already mentioned, is pH injections is for the product therapy. And with the mass opening, there is a much more space. It's very easy to do. At first, with the lidocaine injections to control the pain and to find the angulation and position. After that is pH injections. Is a needle is 2.5 centimeters injected, or 3 centimeters injected to the temporomandibular joint, and 1 and 1.5 cc. In this patient, 1.5 cc was injected. So with that, and 1 month later, patient symptom was gone, but the origin is not complete treatment because occlusion is not stabilized. So we need a much more. We need a much more good to try to making a good position of the temporomandibular joint. So next, finally, about the sinus segmentations. Should implant 7 millimeters, as you see, is good enough. So we have a guideline 7 years before. Nowadays is very successfully used with the compaction drill together. So with the compaction drill bone into the sinus is very stable. So bicortical fixation is possible into the septum. 3.5 diameter is 7 millimeters are good enough. And after the final processes, as already mentioned, is intraoral scanner became to be very precise. So at the time of the final occlusal is very well contact. So with these concepts and alveolar crestal approach is very simplified. So this is one of the beginning times of the compaction race. We relatively have a good result during the follow-ups. So this is a surgery and a little bit labial augmentation together, second stage surgery, and the temporary crown, and the final processes. Long times before, we have used the custom abutment, nowadays not anymore. But with the custom abutment and the temporary crown, because custom abutment is good, but not so much good in the point of the efficiencies. At the finals and the follow-up 4 years, and during 6 years, and we have a very good result. So based on that, and we tried to make a much more efficient treatment for the alveolar crest. So with the collagen graft is a very good enough for the crestal approach instead of the bone grafting. In this case, it's only with the collagen graft. That is good enough for the sinus augmentation, but there is a shrinkage of them, and so we cannot determine the height of the sinus augmentation areas. So we decided to finally grafting of the osteum collagen into the sinus to determine the height of the augmentation areas. Also, in this patient are same with the collagen graft. Also, in this patient, but in this patient is a lateral approaches, because I tried to showing of this video because before we did too much traumatic and longer implant into the sinus, but with a very small incision and flap elevation, because the patient is some problem is a cardiovascular disease, because the patient have some bleeding control drugs. So we do staged approaches, at first sinus elevations, and later place the implant to reduce the trauma for bleeding control. So after the small elevations and the decorticalization with the balls, and when you see some membrane is outside, is too much fast grinding out. So at the time, perpendicular approach to not to grinding out the membrane. So for prevent the grinding out the membrane, so with the circumferential detachment of the membrane with the round instrument and step by step additional detachment. Before we have placed the longer implant at the time, much more problems, but with the 7 millimeter length are good, so sinus lateral approach also becomes very simple. However, we taking a photography and the video taking only 7 minutes, for the good enough for the lateral approaches. So after the detachment, I'm sorry to over the times. And osteum collagen very simply placed, and also pin technique was used for the stabilization of the flap. Very simply without any sutures. Also in this patient have additional some problem in the sinus, so we completely removable of the retention cyst. So this video is a final as interesting because there are some cysts in the sinus, so very simply removal of them. So we must do extraction of the two premolar together. And also, in the instruction site, we do irrigation very excessively. Not so much tried to complete removal of any soft tissues. Of course, we do, but before we tried too much. But also sometimes with the round ball, also sometimes with the laser or electrosurgery cauterization on the apical side to prevent some infections, the complete removal of the infection source. Irrigations. Also lateral grinding out with the balls. There is a relatively high speed, so if you touch to the membrane, that will be grinding out. So if you see the membranes, and at the time the ball is approached to the perpendicular and very lightly touch it. And the initial detachment, already mentioned, that to grinding out the membrane. Little bit widening, because there is some mucous retention system into the sinus, so for removal of them. Also, you can do aspiration and the irrigations to control them. During the sinus augmentation, also you can meet the various one, but relatively sinus augmentation is not so much challengeable, became to be much more standardized in the treatment. So there is a tool in the lower wall, in the upper wall. So not so much is not in the situation no penetration into the cavity of the sinus. So with a very simply collagen graft was placed and the osteocollagen collagen was placed, and the sutures, implantation and the sutures. With the two implant and the temporalization intraoral scanning and the temporary, also we have to place the implant in the lower side together. But the lower side is due to severe defect, you are waiting of the bone formations. Thank you very much for your coming and welcome, and thank you very much our staff to help. Thank you. Thank you.